This is a critical time for patients. Patients count on their doctors to do everything possible to treat their illness. That's the promise that doctors make, the commitment they make when they take the Hippocratic Oath. But many people in Washington now are putting pressure on doctors to limit the care to patients. These pressures are really intruding upon that very important commitment that doctors make to their patients. So in the next few minutes, I'm going to do 4 things. I'm going to present the most dangerous provisions that have already passed into law that will impact patients negatively. Then I'm going to highlight the ideas held by key health policy people in the Obama administration, ideas that are outside the mainstream of American thinking about medical care. Thirdly, I'm going to demonstrate that the United States can afford to provide coverage to the uninsured without limiting the care that Americans who already have insurance choose to buy. And fourthly, if there's time, I'm going to present a low-risk but generous method of providing coverage to the uninsured. Right. So let's get started. The Obama administration has promised to provide coverage for the 46 to 47 million uninsured and at the same time rein in the nation's health care spending. The president's administration argues that they can't get the economy back on track until they limit health care spending. Covering the uninsured is a worthy goal. It's a goal I share. But providing insurance to the uninsured will not save money. Once the uninsured are covered, they will use about twice as many doctor's visits and about 70% more health services than beforehand, according to the Congressional Budget Office. So where will the savings come from? From limiting the health care that Americans who have insurance are able to get. The framework for this top-down government controls on Americans' health care consumption was slipped into the stimulus legislation several weeks ago. That stimulus legislation sets as a goal that every individual's medical treatments will be entered into this nationwide electronic data system. And that clinical protocols will be delivered to doctors electronically on what the federal government deems cost-effective and appropriate care. Now, obviously, having electronic medical records has some important advantages. And undoubtedly, it's also important to deliver information about the latest medical findings and best practices to physicians. It is hard for them to keep up with the rapid pace of medical knowledge. But enforcing uniformity of practice for the sake of cost controls is dangerous to patients. I'm going to put up here a RAND study, one of the most important and often cited studies by the medical community, a study that appeared in the New England Journal of Medicine showing that only slightly more than half the time patients receive the appropriate care for their illness. But the RAND study also showed that overtreatment was rarely the problem, only 11% of the time. Much more often, 46% of the time, patients failed to get the care they needed for their illness. What does this tell us? It tells us that delivering empirical evidence about the best way to treat the patient will not save money, right? In order to save money, the Obama administration is going to have to instruct doctors to limit the care their patients get, limit needed care. Here's Dr. David Blumenthal stating it himself. Now let me identify Dr. David Blumenthal because he's going to play a very important role in this administration. He was recently appointed National Coordinator of Health Information Technology. And here he is explaining that improved medical decision-making is as likely to increase expenditures for underused services as it is to reduce expenditures for overused services. So informing doctors is not enough to save money, right? That is not going to be the purpose of this system. What the RAND studies also showed is that rationing is a blunt instrument. In areas or countries with low utilization of health care, the percentage of inappropriate care is exactly the same as in regions or countries with higher consumption of health care. In other words, when you limit health care consumption, you deny care to people who need it, as well as eliminating the inappropriate care. For example, in Canada, which has a much lower ratio of cardiac procedures to those in the United States, Canada has limited its rate of cardiac procedures almost entirely by denying them to patients 65 and older, according to the RAND Institute. Now, when the stimulus package included these provisions for health electronic technology, the public applauded without reading the fine print. And CNN, factcheck.org, MSNBC all found it incredible. They denied that the language of the bill would permit the Secretary of Health and Human Services to interfere in a doctor's clinical decision-making. But Dr. David Blumenthal, recently appointed national coordinator for this system, admits in his own words that that is exactly what the mission is. He said recently, and was quoted in the New York Times, that his job is not just about, quote, putting machines into offices. April 9th, in the New England Journal of Medicine, Dr. David Blumenthal explained his mission more clearly. If electronic health records are to catalyze quality improvement and cost control, physicians and hospitals will have to use them effectively. That means taking advantage of embedded clinical decision support. Now, the stimulus legislation penalized doctors who are not meaningful users of that system and gives to the Secretary of Health and Human Services total discretion, total authority to decide what a meaningful user is, how much compliance there needs to be. Dr. Blumenthal anticipates that there will be pushback from doctors and hospitals. If requirements are set high, many physicians and hospitals may rebel, petitioning Congress to change the law or just resigning themselves to foregoing incentives and accepting penalties. So in fact, the stimulus legislation does empower the federal government to enforce doctors to make certain clinical decisions on penalty, financial penalty for failing to do so. Dr. Blumenthal has a long history of advocating top-down government controls to limit how much health care Americans are allowed to buy. I'm looking now at his article in the March 8th, 2001 New England Journal of Medicine, where he says government controls are a proven strategy for controlling healthcare expenditures. Now, he admits there are some disadvantages. Government controls on healthcare spending are associated with longer waits for elective procedures and reduced availability of new and expensive treatments and devices. These problems lead to dissatisfaction on the part of both healthcare providers and patients. And he admits that in the United States, most patients get better service, such as shorter waiting times for elective medical procedures. But he says whether that advantage is worth the extra money spent is debatable. Ask a cancer patient, and you will get a very different answer. When you have cancer, waits are deadly. Take a look at the evidence on waiting times in various countries and cancer survival rates. For example, in the United States, women have far better access to regular mammograms than in other countries, and for that reason are far more likely to have regular mammograms. 85% of age-appropriate women get them in the United States. When women are diagnosed with cancer, they also get treated more rapidly, especially if they need radiation therapy, because that involves heavy medical equipment. And women with breast cancer have far better survival rates in the United States than in almost any other part of the world. And these statistics from the largest and most recent cancer study ever done, the Concord 5 Continent Study, published in Lancet Oncology, and from the Commonwealth Fund, reflect the experiences of all women, not just those with insurance.